You know, we're living in a time of great growth for this institution, a time when we've seen major inflection points in all aspects of the business that we are privileged to conduct. So the educational programs are thriving, the research program, the discovery program now has $250 million of annual all-in research funding on the campus. And we're rising in the ranks, I'm pleased to say, of among our peers. And people are noticing. Faculty want to come to San Antonio. More and more outstanding people applying for the vacant positions we have on the campus. So it's truly an exceptional time in that regard. In the area of clinical care, the practice in medicine now is touching 2 million people a year. And our MARC building is going to near capacity in the not too distant future. And many exciting plans, which I hope to be able to share with this body, are underway and hope to come to fruition in the next few months. So truly an exciting time. But rather than belabor those points, I decided a couple years ago that the best way for people to know who we are and what's in our hearts, what we're trying to do, is to have the faculty with whom I'm privileged to work actually tell some of their stories. And in this regard, we're lucky today to have 4 distinguished panelists with us. And here's what I've asked them to do. So I'm counting on you to do that. I've asked them in 6 minutes or less to tell us something about why they do what they do. In the introduction, I'll tell you a little bit about what they do, and you'll be able to discern from that introduction how accomplished these individuals are. But what I've asked them to do today is to tell us why it's so important, why it's such a vocation for them to do this work, and why being here at this time and in this place is a joy. And in telling these stories, I hope that it conveys to you as our distinguished friends and partners in our community as much as we can relay in terms of where our hearts are. So here are our distinguished panelists. I'd like you to welcome them as a group. On my immediate left, Dr. Jennifer Potter, Dr. Greg Awney, Dr. Lisa Cleveland, Dr. Ruben Mesa. So let's give them a big hand for being brave enough to come here today. So we're going to start with Dr. Jennifer Potter, and you may have, if you were listening to NPR this morning, you heard her on the radio this morning telling about what she's doing at the Health Science Center. She is a professor in the Department of Psychiatry and Vice Dean for Research in the School of Medicine. She joined UT Health from the Harvard Medical School, which is a small, insignificant school in Boston, Massachusetts, and the McLean Hospital in Belmont, Massachusetts. She completed predoctoral clinical internship and residency at Harvard and at the McLean Hospital. She received her doctorate in clinical psychology at the University of Georgia, and then she earned a Master of Public Health at Emory School of Public Health in Atlanta. She is a national expert on opioid use and opioid use disorder. Her research focuses on the prevention and treatment of substance abuse disorders with emphasis on opioid use disorders and chronic pain, both in civilian and military populations. She served in a number of, as you might expect, nationally prominent distinguished organizations. She's the National Project Director for the Prescription Opioid Addiction Treatment Study, which is a national study of great importance for our nation in this domain. She's the San Antonio site principal investigator and a co-investigator in the Texas node for the National Drug Abuse Treatment Clinical Trial Network. So a warm welcome for Dr. Jennifer Potter. Jennifer, thank you for doing this.
Thank you so much.
You.
Thank you so much for allowing me to be here today and sharing my story, my family's story, and what I do as part of the UT Health San Antonio family. Forgive me, I have a few notes because 6 minutes for a faculty member is very challenging, and this is to keep me on track because I don't think that Dr. Henrich has his hook, right? I know. Okay. So here I go. Okay. So as you heard, I have been doing substance use and addiction research for a long time. But this past year has been a pretty humbling one for me. And it came from a rather unexpected source because I had the opportunity to do a TED Talk at TEDx San Antonio, which I thought would be a piece of cake, and it wasn't. And if you're interested in that, it's a longer story about what I do. And you can Google it, and then you can find out why I was in Playboy. And it was an article. But seriously, it was, that's the only joke in my talk. but seriously, the whole experience really forced me to think about something that I'd never really taken the time to think about, but actually turned out to be pretty important, which is why I was drawn to substance use disorders research, because I didn't really choose it. I thought I fell into it, but it turns out I probably did pretty intentionally choose it. So just a little bit of context, and I won't bore you with the statistics, and if you turn on the news these days, I'm sure you know a lot more than I thought anyone in this country would ever know about opioid use disorder. It's the leading cause of accidental death right now. In 2016 and in 2017, over 42,000 people died each year. That exceeds motor vehicle accidents. It exceeds death from firearms. And in fact, life expectancy for white men is declining. And we are pretty sure that that's in part because of the deaths we're seeing from opioid use disorder as well as alcohol in this country. That's pretty startling, it's unheard of, and I personally find that unacceptable. So the hard part for me, as someone who knows about treating substance use disorder and opioid use disorder, is that unlike many other diseases that probably interest you, is that this is very treatable. We know what to do. And I just find that unacceptable for a lot of reasons. But one of them is that we have 3 FDA-approved medications to treat opioid use disorder. They're clinically proven to save lives, and if people are treated with them, we see a 50% reduction in death associated with opioid use disorder, or OUD. And those medications, in case you haven't heard of them, are buprenorphine, naltrexone, and methadone. So that leads us to why we can't help with the opioid crisis, because we can. What's happening today in the United States, from my viewpoint, is one of the greatest public health failures of our generation. And the problem is that we have failed to get the access that we need to treatment to the people who need it. And that's partly because our healthcare community doesn't have enough individuals available to treat opioid use disorder, and that many of the individuals who need that treatment can't afford it. But my personal connection to addiction and opioid use disorder is because of the third barrier that I talk a lot about, and that's stigma. So when we think about stigma, it's because one of the reasons that I would argue people don't get treatment is because when somebody has an opioid use disorder, the first thing that happens isn't where will we find the best treatment. The first thing that happens is often deafening silence, and that person finds themselves alone, struggling because no one knows what to do. And that to me is unacceptable as someone who has addiction in their family. And so when we think about it, we have to understand how we're going to bring this out of the darkness. And for me, that's what I do. So this year, I spent a lot of time trying to understand what it was about addiction that I was going to do. And I met someone named Deb de la Garza, and she's given me permission to share her name. I met her because she asked me to join her at International Overdose Awareness Day. And again, remember, I've been working in the field of addiction for almost 20 years, and I went to this talk. I do talks all the time. And I went down there to this day, and I met all of these families, and all of these parents, and all of these beautiful families that had lost a child to a preventable disease. And I gave my talk, and then I ran. I fled. Because suddenly I was meeting people in the community, and I had to look them in the face and realize that I had not confronted the only issue in my family. It was very easy for me to do this from behind a desk. It was very hard for me to do this in an authentic way, integrated with my personal family story. So I made a decision this year, and that's why I do talks like this, and that's why I do talks like the TEDx talk that I did. That when I do work in my research part of my career, I only do things that I know make impact. And for me, the impact that I work on today is about making sure that when I agree to do a project, that project is going to impact a family member or a child's life. That I do work that I know will improve access for someone in San Antonio to evidence-based, high-quality care. That I do work that ensures that we are moving towards treatment on demand. And for me, treatment on demand means that when someone needs help, that help, even if the decision to seek help is at 2 in the morning or 3 in the morning when they are entirely alone, they know that somewhere in our city, they can make a phone call and get the high-quality, evidence-based, science-rooted treatment that will help save their life and improve their lives, because treatment is a beautiful thing, and every life is worth saving. Thank you.
Thanks, Jennifer. Thank you. Thank you, Jennifer. Our next speaker is Dr. Greg Aune. He is the Stephanie Edlin Distinguished Professor in Pediatric Cancer Research at the Greehey Children's Cancer Research Institute at the Health Science Center. Greg is a leader in pediatric research since he has this esteemed position there. He's a graduate of Pacific Lutheran University in Tacoma, Washington, got his MD and PhD degrees in the field of tumor biology and experimental therapeutics from the UT Health Science Center at Houston, and completed his residency in pediatrics as what we used to call the East Baltimore School of Medicine, sometimes known as Johns Hopkins School of Medicine in Baltimore. He's the first graduate of the Pediatric Hematology Oncology Fellowship, supported generously by Mr. Bill Greehey and the Greehey Institute. In addition to conducting research, Dr. Aune and his fellow pediatric researchers at the Greehey are dedicated to patient advocacy, and he's been a key participant in all of these areas. So please join me in welcoming Dr. Greg Aune. Greg.
Thank you for that nice introduction. It's really a pleasure to be here today. I'm tasked with telling you why I do what I do. And I'm a pediatric oncologist, and I do about 20% patient care, and I do about 80% of my time in the research lab. And that sounds kind of boring. I think the more interesting part is why I do what I do. And so to illustrate why I do what I do, I wanted to tell you about one of my favorite patients. So this is a patient that's well known to our service in San Antonio. And he was diagnosed with Hodgkin's lymphoma, which is a type of cancer, in the late 80s, early 90s. And he went through treatment for lymphoma and fortunately survived. And then over the last 3 decades, has experienced a lot of health complications that are the direct result of the cancer therapies that he received. And to illustrate what this patient has experienced, I'll go through them in kind of chronological order. The first thing that happened with this patient is he developed hypothyroidism, a non-functioning thyroid gland from the NECA radiation he'd received. He also developed infertility, which is a common problem we see in our survivor population. had badly scarred lungs from the radiation of one of the chemotherapy agents he got, which has resulted in a couple of very severe admissions to the ICU for severe pneumonia. In his mid-30s, developed severe heart disease, which consisted of aortic stenosis and 3 blocked coronary arteries, which required open heart surgery to replace the damaged aortic valve and bypass the 3 arteries. Patient experienced a mild stroke but fully recovered, developed diabetes, has had numerous skin cancers removed off his back. And the reason that's my favorite patient is it's actually my story. So I had Hodgkin's lymphoma when I was 16 years old. It is the singular event in my life that is why I'm here today. It changed my life in mostly good ways. Cancer is a very difficult disease to go through, and I would argue especially as a teenager. I lost a lot of my high school years were totally turned upside down. I was a really good athlete. I wasn't a good athlete after going through a year of cancer therapy. I lost almost 80 pounds from the treatments I received, but I survived. And around me, I saw a lot of kids that didn't. And in the early 90s, there was still a sizable fraction of kids that didn't survive their cancer. And so I remember telling myself, if I can just get through this, I'm going to do something about it. There has to be a better way to treat cancer. And so with the tremendous sense of responsibility that I gained from my experiences, I went forth and got trained. During that time, the unexpected part of my life trajectory was the realization and the experience of all these late health complications. When I was a patient, the way cancer was presented to me was just get through the treatment and it's all going to be over and your life's going to go back to normal. And what I would tell patients now is cancer is a lifetime disease. There's an acute part, and then there's what comes after. And we have to prepare our patients for that trajectory. And so that's why I do what I do. And it's really one of the most important things we do in oncology, in my opinion, going forward. So right now we have about 500,000 survivors of childhood cancer in the United States. The overall survivor population of cancer across all age groups is going to approach 20 million by 2020. This is a big population. We're kind of in a new area of oncology where what we do to treat patients and how we cure them has to really be focused on what their quality of life is going to be like afterwards, because we know so many of them are going to survive. And so at the end, I wanted to share a quote from Albert Einstein. So he once said, "Problems cannot be solved by the same mindset that created them." And if we look back at the history of oncology, the last 80 years have been really focused on let's cure the patient. Going forward, and what I really want to spend my time on and what I'm spending my time on is let's give our patients that cure, but let's give them a cure without cost. And what I desire for my patients and what I put all my effort into is I want my patients to have my cure without all of those late effects that I told you about. Thank you.
Thank you, Greg. Our next presenter is Dr. Lisa Cleveland. She is an associate professor in the School of Nursing. She is another expert on the opioid use disorder problem in our country, and her research focuses on the care of pregnant women who use opioids and their newborns in the treatment of both of these populations. She's been awarded more than $27 million in funding to address the opioid crisis locally and here in Texas. Her School of Nursing team's efforts include addiction recovery housing for these patients, overdose prevention education, distribution of naloxone, something Jennifer just talked about, and the evaluation of community impact outcomes. She served as a representative of the University of Texas Health San Antonio and the Association of Women's Health Obstetrics and Neonatal Nurses on a national interprofessional committee that crafted the Alliance for Innovation for guidelines that have been written on this national problem, this epidemic that our country's going through. She is a practicing board-certified pediatric nurse practitioner and an international board-certified lactation consultant. She earned her bachelor's degree from the University of South Carolina, her master's with pediatric nurse practitioner specialty from the Medical College of Georgia. She completed a postdoctoral fellowship in health disparities research at the National Institutes of Health. So another wonderful expert on the campus in this terrible problem. Please welcome Dr. Lisa Cleveland.
So, good afternoon. I was so honored to be asked by President Henrich to speak today and to tell you all a little bit about my story, but I have to admit, equally horrified. As academics, we are very used to talking about our work, right, but not so much about ourselves or why we do what we do. So as you can imagine, this has caused a great deal of self-reflection over the past few weeks, and in reviewing my career, I can say that I have honestly, as long as I can remember, have wanted to be a nurse. And so I was going to stand up here today and tell you that's because I care about people and I want to help, right? But then, as mothers do, I had a conversation with my mom a week ago, and she's very good at keeping me grounded and keeping me humble. And she said, "No, Lisa, you've got your story wrong." How many of you all remember the 1970s series Emergency? Does anyone remember that show? Do you remember the head nurse, Dixie? Is there any doubt in your mind who ran that hospital? Right? So Mom said, no, you wanted to be Dixie. And that's probably true. I was a very bossy little girl. And my husband would tell you that has not changed. So. But in all honesty, I think when I reflect on my career, the word serendipity really comes to mind. And I'll give you some examples of that, but I'm truly grateful to have had that serendipity because I would have hated to miss out on any of it. It's been really an incredible ride. So my career began, I am the wife of a retired Army officer, and so my nursing career began overseas. And when you're overseas, because of licensing, if you want to practice as a nurse, you're going to be practicing in a military hospital, right? So I pretty much took whatever position they had because I needed that experience so desperately. And I'll never forget the day that they came to me and they said, "Today we need a nursery nurse." And I said, "Well, that's great, but that's not me, right? I'm not a nursery nurse." And I'm pretty sure I went into that nursery kicking and screaming. But I can tell you by the end of that 12-hour shift, I was a nursery nurse, and that was all I ever wanted to do after that. And as you know, I became more skilled and my expertise improved. I eventually went to work in a neonatal ICU with very sick premature babies. And I absolutely loved it. I loved the responsibility of caring for those little human beings and watching them grow. And what I really loved was the challenge. I wanted to care for the sickest babies with the most gadgets, the most lines, the most monitors, and I loved it and I thrived on it. And then something happened in my life that changed that. I actually became a mother myself. And for any of the women out there who are mothers, you know that that's a life-changing event. And my husband and I were actually blessed to have a very healthy, normal newborn. And I'm pleased to say Jacob is now a sophomore in college. Yes, we got him off to college, and he's doing well. But when I returned to the NICU after my maternity stay, my whole view had changed. All of a sudden, I realized that there are parents attached to this little person that I'm taking care of, and this is probably the worst day of their life. I had always been kind to parents and whatnot. I invited them into the care, but I never really understood what they were going through until I became a mother myself. And so when I enrolled at UT Austin to begin my doctoral work, I knew that I really wanted to study parenting in the NICU and to try to understand if there was a better way as nurses that we could support parents in the NICU. And so while I was conducting that research, again, serendipity, right? I kind of stumbled upon a group of women whose newborns had been in the neonatal ICU because they were born withdrawing from opioids the mother had been taking while she was pregnant. And so I really did not see that coming, but I met with the women, and what I learned over time was these women looked just like me. They were mothers who loved their children just like me. They were not the monsters that media often portrays them as. They were dealt some pretty rough knocks in life, which led them down a different path than I was led down. but they also love their children. And so I really knew that once I completed my dissertation, and I did complete it, by the way, that I really wanted to commit myself to working with these families who had been impacted by something called neonatal abstinence syndrome, which is really just a confusing term for newborn opioid withdrawal. I also discovered, being rather new to San Antonio at that time, that Bexar County has the highest rates of neonatal abstinence syndrome in the state. We have about 1/3 of all cases right here in our community. So that's roughly 300 to 400 babies every year. That's a lot of families who are being impacted by this problem. And so all of the work we are now doing is truly informed by the women we work with. What they identified was a lack of housing where women can go and recover with their children. Typically, the children go in foster care, while women access services, which is horribly traumatizing for not only the mother, but her child as well. And so they came to me and they said, we need recovery housing in this community. And I said, that's great, but I don't do that. You know, that's not my expertise. And they said to me, you need to figure it out. And so we did. We figured it out together, and we now have Casa Mia, which opened in December and is open to women who have substance use disorder and their children, where they can live with their children while they recover. They also brought to me the fact that their family members and friends are dying of overdose. We had a meeting one day, and one of our mom partners, as we call her, Emily, seemed very, very upset. And I said to her, I said, Emily, what's going on? And she said, my husband's best friend died last night in his home. He had Narcan in his drawer, but nobody knew it was there, and no one knew how to use it, and now he's dead. And they said, people are dying, and we're not equipped to do anything about it. And it was around that time the state had come to me and asked, would we be willing to head off the overdose prevention and distribution of Narcan, which is a life-saving medication, for the state of Texas. And I couldn't look at Emily and say, that's not what I do. And so we figured it out. And it's been a really great career so far, and I'm looking forward to more. But so to answer your question, this is why I do what I do and who I am. Thank you.
Lisa, thank you very much. This is an appropriate time to mention that this is the 50th anniversary of our distinguished School of Nursing this year, and at our upcoming gala on September 21st, we will honor the school. Our Dean, Eileen Breslin, is here in attendance today, as you met her earlier, and she and we will welcome all of you to that event at the Grand Hyatt Hotel. And I'm pleased to let you all know that our honorees for this year's gala are two stalwart supporters of the School of Nursing, Karen and Ron Herman. And Ron is sitting here on the front row. Ron, would you stand up and take a round of applause from us? Thank you for doing that. And thank you for all of your support of our School of Nursing. Thanks to each of you who are here because of our School of Nursing. And Lisa, thank you for telling your story. Well, in fourth place, but first in our hearts, is Dr. Ruben Mesa. He is the director of the Mays Cancer Center, the newly named home to the University of Texas Health San Antonio MD Anderson Cancer Center, one of only 4 National Cancer Institute designated cancer centers in Texas. For almost 30 years, the center has had a focus on providing world-class cancer care to this community and beyond this community, advancing cancer research, educating the next generation of scientists to take up this mantle. Dr. Mesa is an international expert on myeloproliferative disorders, a group of bone marrow disorders that often lead to leukemias. He's been involved in MPN research for more than 20 years, and he's led the development of National Comprehensive Cancer Network's panel guidelines, the first United States guidelines on the diagnosis and treatment of myelofibrosis, polycythemia vera, and essential thrombocythemia. Dr. Mesa has been the principal investigator or co-principal investigator on more than 70 important clinical trials in this field. He's currently leading the investigation of several other drugs in these types of cancers. He's earned degrees in nuclear engineering and physiology. By the way, nuclear engineering, Ruben, did you have to take calculus for that? I just have such admiration for anybody who could take and pass calculus. I helped Mary Henrich through her high school years with the calculus. She was just so inept at calculus, I had to help her. You have a different memory of that. Anyway, he has a degree in nuclear engineering and physiology with minors in radiation biophysics and bioengineering. I mean, Ruben, you would have been no fun to be around in college. What are you doing tonight? Well, I'm going to figure out what cesium does when he completed his medical school training at the Mayo Medical School in Rochester, Minnesota, did his residency in internal medicine and his fellowship in hematology oncology at Mayo, and he is a fellow of the American College of Physicians, and he's done a fantastic job in leading our Mays Cancer Center. He's just a welcome addition to our community. So please welcome Dr. Ruben Eisen.
Well, it's a great pleasure to be here today, and this is such an amazing event. You know, I always love coming down to the Pearl, and just amazed how well the horses lived here at the Pearl in this stable. So really, they lived well. So now Bill had told me, and when he says 6 minutes, I mean he's strict about the 6 minutes. But when he invited me to speak here today, he said, tell him a little bit about really why you do what you do. And like so many of you that I've gotten a chance to know over this last year and a half, I in my life, as Greg, as all of us up here, have been touched by cancer in one way or the other. My mother and mother-in-law both had a positive outcome. They had breast cancer. They're breast cancer survivors. However, as Greg very eloquently stated, their lives have never really been quite the same after having gone through that process, been beat up by the therapy, and very grateful for their cure, but at a cost. Similarly, my grandmother died from a brain tumor many years ago when my father was 11. And that really showed me, even early in life, that cancer is a thief. Why cancer bonds us is not because it takes our lives, because we all die. I mean, there's only one way we're all going. But it's about taking life early. And it's about stealing from us all of those memories that will never be formed. I never got to meet that grandmother. My father lost her at 11. She never got to see him graduate from high school or college, or meet his wife, or meet his children. All of those years of life stolen from her. My father himself struggled with cancer throughout his life twice. First, when I was growing up and he had Hodgkin's lymphoma, and I got to witness firsthand the difficulties that he faced. Then, 20 years later, he developed lung cancer in the very area that he had received radiation for his lymphoma. Now, that did not go as well. He had 4 years of having very difficult time with treatment and spread and chemotherapy, and had a very difficult go. And that, too, has stolen now 13 years that I've not had my father. And all of us that have gone through this, I still have my father on speed dial. And every once in a while, we'll want to just hit that button just to be able to tell him about something exciting or good that happened in my life. So cancer steals that from us. So why do I do what I do? Well, first is I view what I do. What is it that I view that I do? First, I care for the patients under my direct care. And that's about being a doctor. That's about being a scientist trying to come up with better treatments. But second, I'm a cancer center director. And a cancer center director is about trying to help a whole bunch of cancer patients, those under my care, but many others, by trying to bring together folks and teams. So how do those experiences really influence both of those things? Well, first, there are many amazing things about the opportunity I have in the role that I play. First, I get to work with some of the most amazing and inspirational people I have ever met. People like Greg Aouni and Jennifer and all of my colleagues are an inspiration for the energy, the spirit, the experiences they bring, the care that they bring to the people here in San Antonio and South Texas. Second, I get to meet amazing patients. There is an intimacy, an honor to be able to help someone and walk them during one of the most difficult periods of their lives in a way that is unique, to share that with their families, regardless of outcome. It is really a very, very special honor to be able to do that. Now, those experiences clearly inspire us in two ways. First, we need to find better ways to treat cancer. So one of the things I enjoy greatest about my job is trying to bring together teams of people who are inspired, who are creative, who are thinking outside of the box, and trying to figure out how do we better prevent, screen for cancer. The best way we treat cancer is you never get cancer to begin with. Second, if you're going to get a treatment, can we make that treatment better? Can we make it safer? Can we make the recovery less difficult? Can we help you overcome that cancer? And then how do we support you through that process? Even if that cancer ends up taking your life, can we do so in such a way that you have dignity, that you're comfortable, that you're at peace with you and your family? Indeed, the second part of what is inspirational to us is how do we transform how we actually care for cancer patients. Cancer care is evolving, and we want to be at the forefront of that. In terms of caring for the individual, what is it that people need, both medically, but them as people, as individuals, so that the care that they receive is one that they understand, one that they're comfortable with, one that their families can help them through. We help them with their distress, the spiritual angst, the difficulty of experiencing this process. And then we help them to recover. And indeed, that is frequently the most inspiring thing that we have the opportunity to do. How do you overcome that, both physically and emotionally? So we focus, we study, we care for cancer, not because we hate cancer. And it's not about death, it's about life. We do this so people can be at that graduation. They can be at that bar mitzvah. They can be with their loved ones and their spouse. And they can live the lives that God has granted them. So it is truly the honor of my professional life to be able to lead the wonderful Mays Cancer Center as we try to decrease the burden of cancer for the 4.5 million people of San Antonio and South Texas. Thank you.
Well, how did they do? Do you think they did okay for these stories? A little out of their... Thank you. Thanks to all four of you for doing this.